Good morning to everyone. Very happy to see a large gathering for our routine programs what we are conducting ISCCM for the student. And congratulations the team of the Dr. Rakesh and the people from the other KIMS group of hospitals for wonderfully arranging the program. With this, we'll move to the approach to the patient of shock. That is the topic given to me to speak. Since morning, I'm listening to all the lectures about all seniors and junior colleagues. I think they have made a lot of efforts to put all things together, and how to utilize in our day-to-day practice is important. So that with continuation of that, everybody is aware about the definition of shock. Shock is a clinical syndrome that results from the inadequate tissue perfusion, irrespective of the cause, leading to inadequate delivery of oxygen and substrate, leading to cellular dysfunction as one of the important cause for causing and multi-organ dysfunction syndrome. It may be differs from the hypotension. Now, when we talk about the shock, in our mind it comes about the basic four things about the patient having an hypovolemic shock, maybe a cardiogenic, obstructive or distributive. This pictorial diagram is self-explanatory. Now, to nutshell, to understand about what happens because of the shock, why you are worried so much about the shock and all things, just we see about the shock which leads to hypotension and compromise the perfusion. Good morning, madam. And it leads to inadequate oxygen delivery, leading to cellular injury. That leads to the production of the various the cytokines and things, leading to functional and structural changes within the microvasculature, leading to maldistribution of the blood flow, and ultimately all these reasons to vicious cycle leading to multi-organ dysfunction syndrome if you are not doing an intervention at appropriately the appropriate time. Now, typically of the basic thing when the patient comes to the shock, what we are going to do is important. First of all, we have to cross check whether the blood pressure what you are monitoring is correct or wrong. The reason since morning all people are insisting of putting an invasive arterial line to show about particular how much BP is there. Because once the blood pressure falls less than 100 or 90 millimeter of mercury, non-invasive blood pressure will be not correct for the monitoring the blood pressure. Once we see the patient in the shock, how much severity of the shock is important to understand. Then the causes of the shock, by going to the history and the clinical examination, we come to the conclusion whether the patient have the blood loss, the patient because of the sepsis or because of the tamponade, or if the patient having typical chest pain with ECG changes, maybe having an acute myocardial infarction. Once we understand these basic things are there when we are in the emergency, in the wards or in the ICU on the bedside, so that what we are going to do it. Now, once we see that, you go according to the ABCD, see about the airway, breathing and circulation, and then we decide about whether to start further medications or not for the patients. Now, a word about the hypovolemic shock or hemorrhagic shock. We are all aware about, since the inception of the medicine, these are the four classes we know. As we all people told about how much the cardiac output is there in our body, so that up to 10% of lost blood is acceptable. When more than 10% of the blood loss is there, then we come into class 1, going to the class 4, almost going to 50% of the loss of the blood volume. In the same way, we see the changes in the vital parameters of the pulse, the blood pressure, the pulse pressure, respiratory rate, as we have nearing from class 2 to class 4. So that what we require, the treatment, what we understand, since morning people are telling when the patient having a hemodynamic compromise is there, the fluid, I think Dr. Mamshi has spoken about what fluid to give. In the intensive care unit, more important is about giving crystalloids. But it reaches to the class 3, you require in addition to the various blood and blood products has to be given for the patient for correction of the shock. Now, a lot of people will argue about there is no need of doing this all invasive monitoring, and they done some study, and they show that we have a lot of experience by seeing the patient, whether the patient is the shock, and they found that only by doing the guess 50% of the time is correct, 50% of the time is not correct. Means every alternate patient we are doing a wrong diagnosis. The reason why this workshop is important to understand why this monitoring is important. Because a lot of people will argue depending upon their infrastructure, things are available or not available on both the sides, why you require so much of extensive monitoring at all places. But then the study has shown that yes, it is important when the things becoming quite complex and difficult. Now, where the things becoming complex, if the patient having ARDS and hypotension, what regularly you are checking the pulse, BP is not going to do workout in day-to-day practice, because the pathophysiology is different, maybe because of the ARDS itself or maybe because of the other reasons, ventilator parameters, patient may be getting an hypotension. If the patients of ARDS and impending acute kidney injury, is difficult how much to fluid to give them, is difficult what fluid to give, how much to give, whether it's causing overloading, underloading. If the patient with a congestive heart failure with septic shock, again becomes more difficult for them with the patient having an LV dysfunction. If the patient having an end organ damage of the cirrhosis, having a decompensated and hypovolemic shock, it becomes what to give, crystalloids or keloids, that becomes a much more confusion for that. If the see about the pregnancy and preeclampsia, if the patient is shocked, it is difficult to identify because there the targets are different and the monitoring range which is given different in cases of pregnancy patients with having PIH. Septic and septic shock is important to monitor the hemodynamics, what we are doing for discussing for last, I think morning from 8 o'clock almost for last 2 to 3 hours. If the patient is receiving the previous medications of antihypertensive medications or nitrates and the patient having cold feriperies, somebody is told in the morning about cold shock and warm shock, it becomes difficult for differentiating between cold shock and warm shock. The physiological parameters we see in the previous slide, the patient having tachycardia, if the patient receiving previous beta blockers or vibradin, patient may not mount the response of tachycardia and it be difficult to say that patient is having in hemodynamic instability or hemodynamic compromise. If the patient receiving diuretics and the output is less for them, it becomes again difficult to interpret about the definition of KidGO guidelines and other things, whether the patient having acute kidney injury or not. So that only the clinical seniority or only doing the clinical examination will be not sufficient. Important to go into the basic history and previous medication what patient is receiving so that we can interpret the data. So that one of the slides they shown that only interpreting the data on the monitors is not important, but important about taking the patient clinical history. If you are sitting here and if you put the monitor, cardiac output monitor, half of the people show that you are your cardiac output less. It doesn't mean that you require the fluid. The reason, the basic thing is about the patient condition, the background, the medications are important before interpreting the data on the machines. Now, what happens with the shock, as we told about the clinical criteria to identify early, if the patients are in the wards, we have the MU scores or medical emergency teams to identify with the patient having shock or not, if the altered mental status, provided that patient is not sedated. Because most of the patients, we have the habit of giving sedation in the ICU, and because of the drug itself causes an hypotension. So that is important to see that whether the patient receiving any sedatives or maybe patient receiving an atypical antipsychotics or other medications and so. If the patient having decreased urine output, as per the definition we know 0.5 ml per kg per hour for 3 hours or 6 hours, a delayed capillary refill time, presence of skin temperature gradient, diaphoresis or skin mottling. The biochemical criteria, we do an ABG, see the lactate, why the lactate is more, try to find out. And if you are having a central venous oxygen saturation less than 70%, or if you are having all the problems difficult to know, so that we see about the arterial to venous carbon dioxide difference of less than 6 mm of mercury, all indicate that patient in the shock. Now, I think a lot of people talk about the invasive and non-invasive monitoring. Both are important at appropriate setup, but as the days are moving, we have more and more sophisticated technology. We are using more and more non-invasive technologies. The role of the bedside echocardiography for the diagnosis of the shock. In the first slide I show the different types of shock. The treatment goes horizontally, completely opposite 360 degree. If you give the fluids for the patient of obstructive shock or cardiogenic shock, it becomes a problem other than the patient having hypovolemic shock or septic shock. The reason is very important for differentiation of the shock. And subsequently we'll show about the blue protocol and false protocol, how to differentiate the shock and how the treatment changes. So that it is important for echo, for early differentiation of the etiology of the shock is important. And not only the etiology, once we start the treatment, is important about how much is sufficient. Too much is giving also a problem, and under the recitation is also a problem, so that whatever you are giving the fluids, vasopressors, is monitoring and titration of the therapy during recitation is important. Because if you are giving too much of high doses of vasopressors without monitoring, they have their own complications and problems. I think the previous lecture they mentioned. If you are not recitating, we see the patient getting into end organ damage in the pathophysiology of the shock, leading to multi-organ dysfunction syndrome, and ultimately all the complications leading to the cell death. So that echocardiography is for the early differentiation of the etiology of the shock is most important. Now, in the nutshell, I will go in the details in the next slide, because in the continuation, why is important about the echo is important to know about the pump, that is the heart, the tank, what is the preload, what you are giving, the pipes of the afterload, and what the treatment. You should decide in first 5 to 10 minutes what required for the patient. So that if the patient having hypovolemic shock, we done an eyeballing on the echo, we see the small or hypercontractile of the various ventricles. It's the same thing in the cardiogenic shock. It may be if you see the heart, it may be dilated or maybe having a regional wall motion abnormality. If the patient having an obstructive shock, we can see pericardial effusion and RV strain. So that a simple doing an eyeballing, just putting in the probe on the chest, we'll see in the more in the workshops, we differentiate with the patient having hypovolemic, cardiogenic, obstructive shock in hardly 2 minutes. So that treatment the differs. If you see about the tank, that the preload, about the when you are doing some cannulations of the vessels in the patient having shock, the vessels diameters will be small or collapsed. But in the opposite way, in the cardiogenic shock, the vessels will be distended, maybe IVC or IJB also. The same thing for the obstructive shock, because of the obstruction, maybe having the distended IVC and IJB, and maybe having an absence of the lung sliding in cases of the patient having the obstructive shock. In the pipes of the afterload, sometimes you just put the probe in the GP sternum and just turn to the right and see about whether the patient having any aneurysm or aortic dissection for them. So the treatment differs. The hypovolemic shock, we give the fluids. The cardiogenic shock, we give the vasopressors, inotropes along with diuretics. And obstructive shock, we see that what is the cause for obstruction, try to relieve that obstruction as early as possible. Seeing the case, what we discussed since morning, we get the typically young patient, 25-year-old female, having history of cough since 1 month, a fever on off since 15 days, and shortness of breath since 2 hours. Once this patient comes to the emergency room or in the ICU, we want to do a clinical examination. On arrival, we just grossly the patient having hypotension, the raised JBP, and having cold extremities. Now the things start what we should do. If the patient having an hemodynamic instability, BP was 100/60, the patient had cold peripheries, the patient was drowsy, what to do? Whether to give the fluids, what lines has to be kept for the patient, what monitoring has to be done, what investigation has to be done is important. So that if you follow in the sequence, the things will be in the appropriate or proper manner. Otherwise, we have a lot of confusion. The reason protocol has to be followed properly is important. As the tradition in the critical care, any patient we see, we perform an ABCD survey. Is important to establish large bore 2 venous lines, and if he is not having, the pediatric patient is there, we have intraocular access, or if you have the time, you have to do central venous line. But important to keep in the mind, when you are in a resuscitation, use peripheral lines than the central lines. If the patient having respiratory compromise, requiring an oxygen, put oxygen. See about the patient condition. If the patient drowsy, GCS is falling for the patient, then if you require intubation ventilation, try to do an intubation ventilation for the patient as early as possible. We do an investigation and see, just doing an ABG, we see about what is the hemoglobin. If the patient having low hemoglobin hematocrit, it may be patient having an blood loss, or maybe patient having leukocytosis. Think about the infection for the patient. If patient having an raised renal parameters, or patient having an finding in the ECG, we understand what we are dealing. Whether we are dealing with the cardiogenic component, whether obstructive component or septic component for the patient. And I think the lot of talked about the PLR, we will not discuss again about this PLR. Now, when we put the probe on the chest and see about the echo, we see about the left ventricular outflow tract. We know the outflow tract considered as the pipe, and we know about the definition of physics from 11th and 12th. The cardiac output, normally we know about the stroke volume in the heart rate. If you want to calculate the stroke volume, is nothing but area and into the distance. So that if you put the pulse wave there, we can see how the thing, and then from there we can calculate the velocity time integral. We'll have more detailed discussions in the workshop stations, but to try to understand how we are doing that one. So that assessment by the echo, as I just told about in the previous slide, what we follow the protocol for the echo about the rush protocol. There is a rapid ultrasound in the shock and hypotension. We go by step 1 by seeing the pump, by doing a cardiac evaluation. Step 2 for the tank for the volume status evaluation, and step 3 for the pipes vascular system evaluation. Now, what we see in the pump is more important about the LV contractility, RV strain, and C for the pericardium. If the patient having an LV dysfunction or patient having pericardial effusion, things will be different. In the tank, we check about the IVC, we see about the pleural cavities, see about the pericardial and abdominal leaks, so that we understand that patient is leaking. It may be hypovolemic component. If the pipes, the aortic aneurysm, might be dissection or deep vein thrombosis. Just in all this examination can be finished in less than 5 minutes. What mnemonic we follow about the high map for checking the heart. It is for the students if you have the confusion at the starting. inferior vena cava, see in the Morrison's pouch and the bladder, aorta and the other veins at the depth, and the pleura and pericardium, so that we understand what problems we are dealing for the patients. As I told about the step 1 about the cardiac evaluation, just put the probe on the heart and see about patient having a massive pericardial effusion causing the pericardial tamponade. It is the cause for the shock. So that immediately treatment requires for pericardiocentesis for the patient, and what we discussed from the other steps, what we follow. We assess the left ventricular the contractility by doing an eyeballing, because in the emergency we don't have much time. Just do an eyeballing and see about the left ventricular contractility. If patient is severely decreased LV contractility, so that we know the patient may be having an hypovolemia, or maybe kissing ventricles, maybe patient having the hypovolemia because of hypovolemia shock, or maybe because septic shock. Then assess for the right ventricular strain, because right ventricle is more for the volume, but if you are changing the pressure, it becomes difficult for them. So that right ventricular strain could be a sign of massive pulmonary embolism causing an obstructive shock. So that just putting a probe on the heart, we understand whether the patient have the obstructive component, or the patient have the cardiogenic component, or the patient have distributive component. Now the step 2, we see about the tank, the volume status evaluation, the tank fullness. I think the previous slide, the previous speaker spoken about the IVC distensibility, IVC collapsibility index. Just for completion's sake, the next slide I'll show you. See about the IVC evaluation. Be seen about their pros and cons, when to check IVC, what are the fallacies are there. The tank leakiness, the fast examination. The tank overload, assessment of the pleural effusion and the pulmonary edema, and tank compromise, assessment of the pneumothorax. So that as we told about the distensibility index, everybody knows about. In the workshop, we'll go into the details how you check an IVC. See that when we are checking IVC, we see about the hepatic veins and the IVC joining to the RA from 2 to 3 centimeter down. From there, we do all the measurements, whether the IVC distensibility index, collapsibility index, or variability index. They have the particular numbers that you have to keep in the mind, whether the fluid responsive or non-responsive. Now the tank leakiness to see is important. We here in the diagrammatically shown here on the right side the probe, if we keep, we know about the at the same time we see about the right costodiaphragmatic recess, see about any collection is there or effusion for the patient. We can see here this diaphragm is a part of the lung and the part of the liver, and then we see about the hepatorenal space, the liver and the kidney, any collection is there, so that any leak is there happening here, so that know the patient having some different problem. The left upper quadrant in the left side in the same size, we see that the patient having left costodiaphragmatic recess. We can see here the left side of the diaphragm and the any collection is there, or a splenorenal space. We can see here any collection is there. In the subxiphoid place, the number 3 here in the diagrammatically, if you put it, we can see here any patient having pericardial effusion. In the pelvic, we can see in cases of the male for the rectovesical space and the female rectouterine space, any collection is there. And if you put the probe on the lung and see about the lung sliding. If the patient having lung sliding is absent, think about patient having some problem. In subsequent slide, I show about the lung point and the pneumothorax and other things. So that when you talk about the tank overload, assessment of the pleural effusion and the pulmonary edema, we can see here. In cases of the hypotension or decreased LV contractility, dilated non-collapsible IVC, signs of pulmonary edema and bilateral pleural effusion suggest patient may be having a cardiogenic shock. Now, typically if you do an ultrasound, previously has been taught air is a very poor conductor of ultrasound, but now whatever the artifacts we are seeing with the ultrasound, we are getting information that and utilizing in day-to-day practice. Now, normally if you are putting a normal lung, the ultrasound, we see about these lines, particularly called as A lines. And if you are having the fluid starting from the pleural line till the end, it coming in the rockets in 2 to 3, it indicates that patient having some amount of fluid overload or fluid collection is calling a B lines. That lung ultrasound, we see A and B lines. If his B lines is there, it means his alveoli filled with the fluid, maybe because of the cardiogenic shock component or other component you have to see, and then decide whether the thing is there, whether to give the fluids or not. Mostly we avoid for giving the fluid for the patient. Now, if in further, when we do put the probe on the chest, the 2 ribs is called as bat wing appearance. Take the 2 ribs, in the between we see about the pearly white line is called as the lung sliding or a pleura. When you put there, we can see here the normal called as seashore sign. Normally we can see here the sea and the shore where things are there. It means the normal lung is moving, it doesn't have any collections or not having the air. But some point, the reason when we are doing and checking ultrasound, we have to check in the particular areas of the 6-7 areas which is given. We'll tell more in the workstations. Not only examining at the single point, we should not be an interpretation. From that point, if you see from particular point patient having a loculated pneumothorax, from that point we see here is having a barcode sign or called a stratopierce sign. That is the point is called as lung point. That's the reason you should make it a practice for after putting a central line, always put a probe on the chest and see the patient having pneumothorax or not. It is having much more sensitive than doing a chest X-ray also. The pipes of the vascular system assessment, what we do, normally we can see if you put in the normally everybody having an IVC assessment. At the same time, if you turn the probe on the left side, we can see an aorta and see what is the diameter of the aorta. Yet at the same time measuring of the aorta, we can see a inner one more flap is there. It may be having an patient having a dissection of the aorta, or maybe an outpouching, maybe having an aneurysms of the aorta. The reason a simple examination will understand whether the patient having the vascular system normal or leaking there. After understanding all these things are there, you are putting in the protocol. What we seen is called as a blue protocol. We put the probe on the lung and see that the lung is sliding. After seeing the lung sliding is there, we see about the profile, whether have A profile or B profile. If B profile is there, patient having a pulmonary edema. So what is the reason of pulmonary edema? You do a clinical examination again, see the investigation labs and try to correlate. So the treatment will differ for the patient. If you do an A profile is there, at the same time we do an DBT screening for the patient. The 2-point compression test, the Mickey Mouse sign and other things they will tell in the workshop more in the femoral area and popliteal area. Then the patient may be having a pulmonary embolism. If the veins are free, if you are seeing the flaps, maybe having patient had pneumonia, we'll see in the more in the workstations about how we see pneumonia. And if no flaps, maybe patient having COPD or asthma. If the lung sliding is abolished for the patient, and we see in the previous slide, patient having a lung point is there, is the confirmatory diagnosis for the pneumothorax. If patient having much more issues and problems are there, we can confirm by doing CT scan and do an appropriate assessment for the patient if require an ICD or the decompression of the lung. The false protocol, the fluid administration limited by the lung sonography. If the patient having acute circulatory failure or hemodynamic compromise, we do the cardiac sonography and we see in the previous the slide I showed patient having a tamponade or pulmonary embolism, and then obviously the diagnosis is about the patient having an obstructive shock. And if you are doing a lung ultrasound, we follow the blue protocol which is there for the patient. A profile is not having other things, and if having the patient having in the lung ultrasound we see the lung point, pneumothorax, the both reasons is for the obstructive shock, treatment will differ. Not to start vasopressors or food for the patient, treatment will be different for this type of patients. Further proceeding about the lung ultrasound, we see the B profile is there, definitely patient having pulmonary edema, mostly because of the cardiogenic reason, provided that you rule out the kidney and liver problem for the patient. We see the A profile and further follow the false protocol. There is no clinical improvement and B profile is generated, maybe the responsible because of the septic shock. In the false protocol, we are given the fluid therapy and showing the improvements in the various parameters what we have seen. Mostly it will be a hypovolemic shock. So that if you follow the blue protocol or the false protocol, we come to the conclusion grossly what is the type of problem we are dealing, what are the type of patients we are dealing, and give the treatment accordingly for them. The word about anaphylactic shock, the treatment is adrenaline. Neurogenic shock, see about what the patient, because the topic is given approach to a shock. Neurogenic shock, see what the patient having the problem and see about the patient having the lesion about T6, we give norepinephrine, below T6 we give phenylephrine, and if the patient having an bradycardia, maybe requiring atropine, and important is there whether we are able to fix the spine early or not. So that what we, the ISCCM in 2014, they given a consensus definition what we should do following in cases of hemodynamic monitoring. Is important about frequent measurement of the basic vital parameters, heart rate, BP, temperature, physical examination variables from time to time. A single measurement is not sufficient to making a diagnosis. We recommend not to use a single variable, as I told, either a clinical parameters or investigations. Important, all you have to putting together the clinical parameters, investigations, and the lab parameters. Important to identify the shock as early as possible, so the treatment differs for each type of the shock. The presence of the arterial hypotension is important for posing an invasive pressure monitoring is important, and is not necessary to have the hypotension for definition of the shock, that what they mentioned. The routine screening of the patient at risk to allow early identification of the impending shock and implementation of the therapy is important. Recommend further hemodynamic assessment, determine the type of a shock if the clinical examination does not lead to clear diagnosis is important. The take home message, Shock diagnosed by the clinical and biochemical criteria with supporting about the non-invasive monitoring or invasive monitoring. Echocardiography is a must for each and every person and recommend for each and every trainee and other people to do repeatedly because learning curve is quite small for learning the echo. Early differentiation of the etiology shock is important and monitoring and titration of the therapy during the resuscitation, whether they give the fluids or vasopressors. Eyeballing is important in cases of emergency than doing routine measurements. What we are doing routine echo or cardiologists, therefore doing routine measurements is for the stable patient. When the patients are unstable, by doing just 2 minutes. By doing the eyeballing is sufficient to get the gross value what the problem is there. We talked about the rush examination, seeing about the pump, the tank and the pipes is important every time. And the high map protocol just to follow whether the patient having leak in the abdomen because of the blunt trauma or because of the aneurysms or other things are there. And if you follow the blue and false protocol, then most of the times I think 80 to 90% of the time will be correct. And avoid fluid in presence of the B lines. Thank you.